Hello everyone, this is a continuation of our discussion regarding prothrombin time and activated partial thromboplastin time. So we start first with your prothrombin time. In the year 1935, Dr. Armand Quick described this test to indirectly measure prothrombin in plasma, which is dependent on the presence of fibrinogen, thus getting its name prothrombin time. Subsequent discoveries of factors 5, 7, and 10 showed that prothrombin time is a reflection of several factors and not only prothrombin. Thus, the prothrombin we use at present is now a test of choice for determining deficiencies in the extrinsic and common pathway factors. Although prothrombin time is no longer a measure of prothrombin itself, it is still the test of choice for monitoring anticoagulant therapy by vitamin K antagonists such as your warfarin. Remember that factors 2, factor 7, and factor 10 are the coagulation factors that are most sensitive in the prothrombin time measurement. As mentioned in our pre-lab discussions, citrated platelet-poor plasma or citrated plasma is the specimen of choice in this test. For the reagents used, we have your Thromboral S, which contains your tissue thromboplastin and your calcium chloride. We also use your lyophilized controls, which is usually in 3 ranges: the normal, the low, and the high range. These are used to determine the quality and integrity of our test. As you recall, the following are the procedures in the prothrombin time. Aliquots of the patient's plasma and the PT reagent are warmed at 37 degrees Celsius for 3 to 5 minutes. Afterwards, 0.2 milliliters or 200 microliters of the reagent was transferred in the 100 microliters of the patient's plasma. A gel-like clot formation indicates the result of the test is achieved. The time is then recorded. For the controls, the patient's plasma is replaced with the controls and the same procedure is done to check the integrity of the test. For the principle of the test, when tissue extract or tissue thromboplastin, which is our reagent, is added to the citrated plasma along with the calcium, it reacts to factor 7, which triggers the extrinsic pathway and the common pathway. Factor 7 then activates factor 10 to 10A. Then factor 10A along with factor 5, phospholipid, and calcium converts prothrombin to thrombin, which subsequently converts fibrinogen to fibrin. The time from the addition of the reagent to the formation of the clot is reported as the prothrombin time result. Normal values differ with the reagent and methods used, but for our discussion and laboratory exercises, values ranges from 10 to 13 seconds and sometimes reported together with your PT-INR. Prothrombin time may be reported in several ways. 1. The patient's result plus the normal values. 2. The patient's result and the control results. And 3rd, the patient's result together with the PT-INR, which stands for the International Normalized Ratio. This is to standardize the method of reporting regardless of the kit that you use for the prothrombin time. But among these 3 reportings, number 1 is the most common and preferred choice of reporting the prothrombin time results. Incorporated with your PT-INR is the ISI, or the International Sensitivity Index by the World Health Organization. This is a calibration parameter that defines the responsiveness of the reagent relative, which by definition has an ISI of 1.0. ISI is assigned by the manufacturer to each commercial reagent. Thus, ISI differs per batch. An ISI of less than 1.0 denotes a more sensitive reagent was used in the test. Prolongation of the prothrombin time indicates an abnormality of one or more common or extrinsic coagulation factors. Prolongation may also occur with factor inhibitors. Disorders such as your disseminated intravascular coagulation disorder, your liver disease, and vitamin K deficiency may also be associated with abnormal prothrombin time results. Prolongation of the prothrombin time indicates an abnormality of one or more common or extrinsic coagulation factors. Prolongation may also occur with factor inhibitors. Disorders such as your DIC or disseminated intravascular coagulation, liver disease, and vitamin K deficiency may also be associated with abnormal prothrombin time results. We proceed now to the activated partial thromboplastin time, or APTT. Your thromboplastin in the coagulation cascade is a lipoprotein that initiates the conversion of factor II into its active form thrombin. Without the thromboplastin, formation of clot is not achieved and may indicate coagulation factor deficiency or presence of inhibitors or antibodies. So, your APTT measures the time required to generate thrombin and fibrin polymers via the intrinsic and common pathways. It is the test of choice to monitor individuals undergoing heparin therapy. Similar with your prothrombin time, your APTT uses citrated platelet-poor plasma or citrated plasma as its specimen of choice. In the APTT, we have two reagents, the APTT reagent and the calcium chloride solution. For the APTT reagent, or prothrombin SL, it consists of platelet substitute prepared from brain or plant phospholipids and the negatively charged activator, kaolin, selite, ellagic acid, and micronized silica gels are some of the activators used in the APTT reagent, depending on the manufacturer. In this case, in the prothrombin SL, it uses ellagic acid as its activator. We also use the controls in APTT. For the procedure, the patient's plasma is added to reagent 1 or the APTT reagent and is then incubated at 37 degrees Celsius for 5 minutes. Afterwards, the addition of the second reagent or the calcium chloride solution is done and the time for the clotting to occur is then recorded. Same procedure is done for the controls. It is recommended to use 2 controls per run of the test. The APTT measures all factors except factor 7 and factor 13. Partial activation is done during the addition of the first reagent, which has your thromboplastin. Maximum activation is achieved when the addition of the activator, such as your silica, ellagic acid, cellite, and kaolin, as it triggers the contact factors 12, prekallikrein, and your high molecular weight kininogen. This then activates your intrinsic pathway. Phospholipid is supplied to substitute for platelet factor 3, which is needed in the intrinsic pathway. Calcium ions in the blood were chelated or sequestered by the anticoagulant use. Thus, the calcium chloride as the second reagent is added for the recalcification of the plasma, thus forming now your gel-like clot formation. The ranges differ according to the reagent, method, and instrument used. But for our discussion and lab exercise, we use the normal values of less than 35 seconds. A prolonged APTT in the absence of heparin use indicates a factor deficiency. An acquired circulating anticoagulant such as the lupus inhibitor or an antibody specific factor such as factor VIII antibody. Sources of error for PT and APTT may be grouped into 3 categories. You have your sample collection and preparation, reagent preparation, and your instrumentation and personnel. For the sample collection and preparation, improper collection and transfer of plasma and processing of the specimen may significantly affect the results. The anticoagulant and blood should also have a correct ratio. Underfilled or overfilled tubes may result to erroneous results. The anticoagulant volume should also be adjusted to individuals or patients with hematocrit higher than 0.55 and less than 0.20 to avoid error caused by the anticoagulant to plasma ratio. Hemolysis may also cause falsely shortened results. And also, unexpected heparin contamination from heparin locks can lengthen APTT and PT results. For the reagent preparation, reagents may be affected by the improper storage, water impurities or contamination, and incorrect dilutions. Reagents should be tested for sensitivity every now and then for the integrity of the test. Now, for the instrumentation and personnel, if the PT and APTT is performed in a semi-automated instrument, failing light source may be a cause of error. Fluctuations in temperature during incubation may also cause erroneous results in the course of the test. And lastly, if the tests are done manually, subjective judgment by the medtech may also cause an error and may affect the timed results. That ends our discussion regarding prothrombin time and activated partial thromboplastin time. Here are my references for this discussion. Thank you.